of that kind of work.
Oh yeah, firefighting. Okay, we're ready to start.
Just quickly, can we check the audio from all the teams just before we start?
Yeah.
Can you please unmute team 1, team 2, team 3? Please say something just to check your audio.
Just say check or whatever.
Are we audible, sir?
Yes. Team 2 has only one participant. Your colleague is there?
Yes, sir. Yes, sir. He's there.
Okay, fantastic. Jaydeva, we've got an all-ladies team. All the best.
Thank you, sir.
So can you just speak something and just confirm that you guys are connected?
Yes, sir. Team 1, Jaydeva, sir.
Yeah, so that's Lakshmi and
Aparanji.
Dr. Aparanji. Yeah.
Yes.
And then
Team 3.
Team 3 from All India Institute.
Dr. Asharam Banda and Dr. Sumit Kumar.
Good evening, sir.
Terrific. Good evening. So
Thank
shall
you
we
so much.
start?
Yes, sir.
Yeah,
Recording in progress.
Yeah.
Basically, invite everyone to this first seminar of the year. First of all, wish you all a very happy new year. And it's great to see all of you once again after a hiatus of around 2 to 3 weeks. And it's great that we are having our former teachers here, as well as Dr. Tarakan and several others. And there's an interesting quiz. I mean, it's going to be a feast in terms of the variety of questions that we have and the cases that will be demonstrated. So with that, let me hand over to Dr. Krishna Kumar.
Welcome everybody, and again, we've decided to start this year with the congenital heart quiz. This is a format that is very popular with the students, and it seems to moderating, perhaps the best you can get from the best of institutions. So we have Dr. Ramakrishnan, who is an extraordinary teacher and who has terrific clinical material to start with. And then we have Dr. Jayaranganath from Jaydeva, who's prepared a wonderful set of X-rays and ECGs to test you. Dr. Navneeta, my colleague, will be testing you with clinical scenarios, and that will be followed by Dr. Arun Gopalakrishnan from Sri Chitra, who will be presenting some echo scenarios, and then it will be Saurav Gupta. Of course, if time permits, we'll get Dr. Ramakrishnan once again, because he has lots of interesting stuff to share with you. Amongst the moderators, we have some really eminent people, Dr. Taragan, Dr. Anita Saxena, and Dr. Sanjeev Sharma. These are stalwarts who will take you through and add a lot of wisdom to the questions. And of course, we have 3 teams. We decided to limit it to 3 teams because we thought we should use this to enable maximized discussion. And we realized in the previous quizzes we were rushing through. So today we'll take it a little easy. One important point is for all the teams not to be fixated on your points, on your scores, because this quiz is an excuse. The real goal is to learn. So don't worry whether you win or not. Of course, there will be a semblance of a competition so that you take it a bit seriously and you make an effort to answer right. But then it doesn't matter who wins at the end of the day. With that, I'll hand over the forum to Dr. Anita Saxena to make some of her comments and to start this session in a way to inaugurate the process for the next year as well. And then we will go on to the quiz as such.
Thank you. Thank you, KK. Again, good evening and a very happy new year to all my colleagues, students, fellows who are attending. I think the PHFI Masterclass is almost covered full 1 year, or it's about to cover 1 year. You started in March, I suppose. So I think it's been very, very popular program. And as KK said, that this quiz is always something that people are very interested in. The students are very interested in. But again, the real test will be in case discussions and journal clubs and all that. So we're probably going to have a lot of fun today. It's a quiz completely dedicated to congenital heart disease, including starting from clinical, X-ray, ECG, echo, and everything. And
So Tarkan sir is muted, I think.
Oh, I'm sorry. No,
Yes, sir.
Yes, you're audible, sir. You're
Yes,
audible
I'm
now.
audible now, sir.
I think the team is muted.
Yeah, team Jayadeva, you have to be unmuted.
You start reading at least. And then
Start reading
Yes.
this.
Yes, sir. This is a 23-year-old with CHF. The SVC saturation is 41% and RA saturation is 87%, suggesting that there is a step up at the level of RA. And the other saturation, femoral artery saturation, is 97, which is normal. Coming to the pressure data, the
And you should
RA
mention
pressure,
about SVC also, whether it's
Yes.
normal or abnormal.
SVC 41% suggests that there is a patient is in low cardiac output state with increased oxygen extraction, that is mentioned as CHF.
Yes.
And the RA mean pressure is 14 and the pulmonary artery wedge pressure is 23 mean, and LV end diastolic pressure is 11, sir. There is also increased pulmonary artery wedge pressure, and the RV and PA systolic pressures are also increased, that is 80, with mean pulmonary artery pressure of 45. So this is a case of left to right shunt at the level of the right atrium with probably mitral stenosis with the pulmonary hypertension pulmonary arterial hypertension with the patient presenting in pulmonary edema with congestive heart failure. Final.
Oh, that's fairly okay. You, of course, missed that SVC 41. It's very extremely important. You are dealing with a sick patient when you get a saturation of 41 with an arterial saturation of 95. That means the patient is in low cardiac output, whatever be the underlying heart disease. Number two, you have normal LV pressures, 100 by 11, right? While we have only V, you don't have the A waves. Obviously, probably there is a reason that he may be in atrial fibrillation. Why do you say it's mitral stenosis? Why not mitral regurgitation?
Sir, there is a diastolic pressure gradient between the pulmonary artery wedge and the LV and diastolic pressure, which is mentioned here.
Pulmonary artery, no, that's what I go to come again. Pulmonary artery diastolic is only 27, while the pulmonary wedges mean 23. So transpulmonary gradient, so-called end diastolic gradient, is only 4. That doesn't qualify for pre-capillary pulmonary hypertension, truly, isn't it? You understand?
Yes, sir.
Yes.
So this was a real patient's data. Patient had somewhat kind of an acute subacute MR actually.
That's correct.
With an ASD. So that's why this cardiac output was so low. The QS is 1.6, and the patient was in atrial fibrillation.
Yeah.
So even though you are saying about the gradient, as Cyrus pointed out clearly, the pulmonary gradient is so low. So this patient had
diastolic transpulmonary gradient.
And then another interesting thing is, even though this patient has ASD, these are real pressure from a real patient. I think the RA was 14 mean and a wedge of 23 mean.
Yeah.
So maybe it was not fully wedged, or it was not properly wedged. That could be another reason.
Yes.
Rama, this patient actually has had VSD with TR, MR and TR.
Yeah, it's possible. Again, see, RV end diastolic is 10, while the V is again 24. Now, this can be two reasons. One, of course, transmission of the RV pressures into the RA, but more importantly, is likely to be a transmission of the LA pressure into the RA. Right? In all mitral disease, Luton pressure or mitral regurgitation, you will find the LA pressure reflects on the RA as well. So that also is another possibility. So I think we have covered almost everything. Low cardiac output, large shunt is really not important because the patient is much sicker. But of course, here probably is that, I mean, the good thing is that he's sick because of an acute. Any acute mechanical problem, however sick the patient, his prognosis is better because mechanical correction gives you a very sort of a very good result. I think we have covered most of it. As I said, it is probably passive pulmonary venous hypertension, partly contributed to the large flow into the pulmonary arteries, so that the PVR actually, it's not calculated here, but it couldn't be more than 2 or 3. So which could be very well in the realm of flow related as well as pulmonary venous hypertension related pulmonary hypertension.
So like in terms of differential diagnosis, as Madam pointed out, this could be VSD with TR with MR. Okay. Even though that cannot be made out clearly from just the hemodynamics head, but if the hemodynamics are real, then this cannot be actually ASD per se.
Yes, that's my objection is that if you have a wedge of 23 mean and an RA of 14, considering that your wedge is real, it is unlikely to be a large interatrial shunt.
It has to be PA-PVC along with that, right?
Or as I said, I think if I remember correctly, this patient had VSD with MR, which was, and of course TR, which was responsible for high step up at RA level and a difference between wedge and RA pressures.
Oh yeah, I think that's also a good point. Certainly, yes, VSD. But of course, this looks a much sicker patient. So
yes,
usually,
patient was very sick, sir. Actually,
sir, should we be considering RSOV to RA as well, considering the sickness, the acute state, and all other things?
The LV EDP of 11. That actually takes you away from acute volume overload of the LV except mitral regurgitation. Even mitral regurgitation, acute MR, the LV EDP would be high. That was the reason I thought it may be all chronic mitral valve problems with mitral regurgitation, very mitral stenosis, and the entire thing. Because LV EDP is low.
We'll move on to the next question. We've exceeded somewhat the time, but that's terrific. So let's go on to the next question. So
no, I think maybe KK, it would be useful to have the question. I mean, we'll move to the next question, but yeah, briefly, that's because he's making a good point there. If you go back to the next slide.
The previous slide, yeah.
Yeah.
So this
So
is a
like
question where we
the
had
questions were like atrial fibrillation is likely, two pathologies are likely, borderline operability and low output stage. So low output stage, immediately you make out from the low SVC saturation. That's a very important key thing, that immediately when you are catheterizing also, you find a dark blood coming out of SVC. If you are a fresher, always call for help. That is a warning sign before you do an angiogram, that any black saturation in SVC, stop for a while, call for help, and be sure that what you want to get, targeted cath and come out. Patient is very sick. And obviously, this is not a borderline operability. QB/QS is 7:1, so no need for thinking in that line. So even though pH is nearly systemic. And obviously, there are likely to be two pathologies here, definitely. And atrial fibrillation is likely because no AVFs are mentioned here.
So what is the final diagnosis?
So this final diagnosis is what Madam told, sir, but that is almost impossible to make out from.
Yeah, that's fine. That's
from
fine.
This thing, I think they are given ASDMR that we will accept it like.
Right. Okay. No, I'm basically asking that to award the points. So I think
we
they
should
almost
I've awarded the points already, Prabhakar. I've already awarded the points. I've given Jaydeva's team 7.5 out of 10. They got almost everything right except for the low cardiac output. So I think we'll move on.
Right. Thanks.
So
Rama?
team
2 gets this question. 3-year-old with cyanosis since birth.
This data, first coming to the saturations, we find that there's a step up between from RA to RV, sensitive of an ASD, or sensitive of a left to right side at the level of RV, and then we have that we see that there's a step up in the PA. However, we also see that the aorta saturation is less; it is only 70, and it is similar to that of the RV. And on the other hand, the LV saturation is 87, which is similar to that of PA. So it is of transposition physiology. And we also find that the pulmonary vein saturation is a bit less. It is only 94. And there's a step down from pulmonary vein to LA. So we have a transposition physiology with a step up at the level of RV and a step down at the level of pulmonary vein to LA. And coming to the pressures, we find that the RA pressure of mean of 6 and LA pressure of mean of 5 are nearly similar. So it can so that there can be the presence of a ASD. The RV pressure is much more higher than that of the LV. So there can only be a restrictive VSD as such. And also we find that there is a gradient between the LV to PA, which is of around 14. So mild PS is there. There is no PAH, and there is no gradient from aorta to LV.
So what is your final complete diagnosis?
Sir, it's a case of transposed red arteries with ASD and with a restrictive VSD with mild PS and
intact septum or intact septum or restrictive VSD.
Sir,
intact septum or restrictive VSD. Most likely likely to be intact septum, like
intact septum or restrictive VSD, and with mild PS only.
So what will be your that could be flow related. How much PS you will accept, like how much gradient across a semilunar wall is acceptable generally? How much gradient across a semilunar valve is considered?
Sir, till 10 or 15 can be the,
so it's generally cath gradient is 25.
10, 25.
25 is significant. So this could be insignificant flow related actually.
Yes.
So what will be a final plan, like plan for the patient?
Sir,
Why do you catheterize? Basically, why should you catheterize a 3-year-old with TGA intact septum?
Sir, to see whether the LVS regressed or not.
So what do you think here? What is the pressure generally needed by hemodynamics like?
We can't hear him.
We can't
Hello?
hear you.
Can you just yeah? Can you just repeat what you said from Chitra?
The LV pressure is less than half of the RV pressure. So
yeah.
More than 2/3 of the systemic pressure.
So we need 2/3 of systemic pressures. So suppose in this patient, so for sake of discussion, suppose LV pressure is 75. Is there a concern in this patient? Patient is 3 or 4-year-old. LV pressure is 75. There is no VSD, intact septum.
And the PA pressure is also 75. Is
PA
that
pressure
what
is also 75.
And would you be happier with that situation or this situation?
When there is PH, then we have to look for the operability.
So then the operability issue comes up. All this is because of the vascular obstruction, primarily in an intact septum. So, sir, you want to add anything, sir?
I just want the team to correct their mics because there were lots of good points you were making, Sri Chitra. But please keep your audibility is been suffering a little bit.
I think that actually covered almost all.
Yes, I think it's all covered. It's 10 on 10.
Only thing is when you come to the surgery, obviously that LV pressure being a bit low, it has to be probably a 2-stage. That's all. To train the LV, at least for a short while, and then do an arterial. But I think otherwise everything looks fairly okay for an intact septum transposition. Probably the shunt is bidirectional at the atrial defect level, though the step up is seen more evident in the RV. I think overall I would vote for ASD with bidirectional shunt in the T. No significant PS.
I think for the audience, I think their approach was very systematic, and that is how you have to approach. And that's very important. And I would suggest that whenever a desaturated patient is given, always look for aortic saturation. If it is desaturated, always look for this pattern. Like whether PA is higher than aorta, that immediately tells you that this is likely to be a transposition physiology. If all of them are equal, then you think of a admixture physiology. So immediately you will make out what physiologies are there. Then you can move up to step up and step downs. That will make your life easier.
That's correct. I think that's right. You have to address on 4 points: mixed venous, pulmonary artery, aorta, and pulmonary vein. And then immediately you know whether it is a right-left shunt, left-right shunt, admixture, or transposition. So these 4 saturations you should always address first. That's right. But they have done well.
Very good, sir. Very good. Yes, sir. So the questions are the same, like ventricular septum is intact, ASD is adequate, ASO is the procedure of choice, and oxygen study is less helpful. So the answer is ASO is the procedure of choice. That is not the right answer. So generally we need a 2-stage switch, or a sending will be an appropriate surgery in most of the centers. So these are the steps that they have found out. For want of time, we'll go to the next one.
Team C from All India Institute, just go through the same process. Unmute yourself from All India Institute. Just unmute yourself. Okay, suggest you start analyzing the numbers.
Yes, sir. So, say 24-year-old who had a murmur in childhood, now with a dyspnea and heart failure. So SPC aortic saturation is 96, so we are dealing with a acyanotic condition, and SV saturation is 56, which is slightly lower, with a significant step up from SPC to RA and also to RV, and so step up around a significant step up from SPC to PA, and in pressure data, RA pressure is high with more than both A and V are elevated. RV more than LA, and RV pressure also elevated. There is no gradient between RV and PA. LA pressures and LA, LV, and aortic pressures are normal. So there is a significant shunt at the level of right atrium. LV to RA.
You want to comment something on the aortic pressure, or that's also
pressure?
Okay?
There is a aortic pulse pressure is high. LV to RA. And most likely there is a shunt. LV to likely RA. RSOB to RA. RSOB to RA or RSOB to RV with significant TRs.
Okay, you can I come in?
Yes, yes, sir, please.
Yeah, but what about this murmur in childhood?
Sorry.
You think it is not important? A murmur in childhood picked up and this hemodynamics, what does it tell?
Most like then it's likely a coronary cameral fistula or coronary.
Just because Dr. Taragan asked you a question, don't run away from your diagnosis. You need to interpret and put these two into context.
Something can be associated with the RSOV.
You know, it's very unusual for coronary cameral fistula to, you know, have a long-standing murmur and present at with heart failure with these numbers. It's exceptional for it to do that.
Okay.
So
suppose this is an RSOV from the right sinus. What is it associated with common?
Most likely it's associated with a VSD in childhood.
Okay, so when you get
what kind of VSD?
Yes, usually RSOV the right side from the right sinus usually associated with VSD, but the support mechanism is involved. I think fair. Why is it not a VSD with AR? Just 2 or 3 highlighting points for everybody to.
Yes.
VSD with AR who is in failure, so LVED should be high, sir. LVED is not.
I think even RSOV with failure, LVED should be high. So I think that anyway it's a little
LVED is not fitting. Yeah, it's not fitting.
It doesn't matter. If you pointed it out, it's fair. Instead, the EDP would be higher in RSOV than in AR because AR is a chronic process. Where does the RSOV start occur? When does AR occur in a VSD? Very simple questions.
RA pressure should not be very high in VSD.
No, you are not answering my questions. Very simple. When does an RSOV occur in the setting of a VSD? When does AR occur in the setting of VSD?
Sir, AR is due to cusp prolapse.
When does it occur means timing. VSD with AR, the AR usually sets in the first and never for the first time occurs beyond the second decade.
Yes.
RSOV rarely occurs in the first and second decade. It usually occurs in the third decade or beyond, generally third decade. That itself also is the chronological order. You know, he has been suddenly symptomatic. Just only thing is the sudden word is not there. It's recent. Still, I think RSOV would be the choice. Rama?
Yes, sir, I think this was a patient with RSOV, but I think the ED is something that should be higher. We expected the ED to be higher.
Yeah.
So it all depends on the duration of RSOV, the ability of LV to adapt, and a lot of things, other things come into the picture, right?
Even your LA is very low, surprisingly, and there is a fairly significant transpulmonary gradient. So those are a little odd, but nonetheless, there isn't a better explanation. So I think it's reasonable. And I have given this team 8 out of 10 points. Just for a couple of points have been taken off for the analysis that wasn't perfect, but that's fine. Still go on. And I think we are, you can show that question.
So I think we had discussed it around it, like in the previous case also we had all these discussions happening. So we'll, for a lot of time, we'll go to the next one. For the audience one, quickly, sir.
Audience round, you can go to the audience round and display the options after you've
So these are the waves that are, the pressures are noted here. The pressure that are given are descending aorta in the red, the main pulmonary artery in pink, and left pulmonary artery in yellow. So we noted all of them. So we'll go to the question. So what is this phenomenon?
So go back to the trace because
please go back to the trace, Rama.
We were not sure of what was going on. LPA is 12 and MPA is 65 by 4.
So should I launch the poll, sir?
Yeah, you should.
I think you can launch the poll.
Yeah, that will be easier for the audience to answer it now. Launch the poll, please. And the audience can move the poll window to be able to see the slide also. It's a nice example, Rama. Thank you.
Thank you, sir. So I think most of you got it right. So this is ventricularization of PA trace. So what are the causes of this? Any team wants to answer this? When do you get this ventricularization of PA trace? So like you can see, it's very simple. Like they are like, just to confuse you, all the options are given. Otherwise, it's very simple. The MPA looks like a ventricle. That's all.
Peripheral pulmonary stenosis, sir.
Anything else? Good. Anything else?
After tetralogy, when you have a transannular patch, you can get a similar sort of
PR,
situation.
associated PR when there is there. Yeah.
So
thanks, Kate. You came to that point. You see, if you look at the PA tracing, proximal PA tracing, it actually resembles exactly the RV. Now, this can occur only if there is really no pulmonary valve. Right? If a pure pulmonary stenosis, supravalvular pulmonary stenosis, there is ventricularization, but there is a continuous diastolic drop in the PA pressure to equalize the RV pressure. Here it's not like that. Here it's almost in diastole, it's going up. So really you cannot tell from this place that it is of the PA or the RV. This can happen only if it's a free flow RV outflow, right? So I think that's correct. It must be a transannular patch, a post-tetralogy, or whatever it is.
Yes, sir.
And of course,
stenosis, along with LPA stenosis.
And obviously, the stenosis must be fairly proximal. That is why you have this PA. Good. So or type 1 peripheral PS.
Yes, sir.
Right, Rama?
Yes, sir. Thank you, sir. I think I'm done, sir.
Terrific. I think we've had a very good round with Ramakrishnan. And I think now we'll go on to Jay Ranganath and we'll have Dr. Anita Saxena moderate this session. So Jay, you can start with this and we'll go in the reverse order. We'll start with All India Institute as the first team that will take on this question.
So, sir, can I tell the scores for after round 1?
Yeah, you can. You can you can announce it quickly, but as we said, we are not particularly excited. I'll announce it for you. We have team 1 that got 7.5, team 2 that got 10 on 10, and team 3 got 8 on 10. But I think we'll not focus so much on the scores.
Yeah, they're all doing well.
We'll keep going. Yeah, they're all doing well, and they all understand what's going on. But I like the Sri Chitra's analysis, as Rama said. Of course, they had the advantage of a slightly easier question also. Let's go on. Is Jay sharing his slides?
Yeah.
Terrific. He's got a really nice set of X-rays and ECGs, so we're very excited about that.
Shall I start, KK?
Yeah, please.
Shall I start?
Yeah, please.
Okay.
And Dr. Anita will be moderating this round.
Okay. Good evening, madam.
Good evening. Good evening, everyone.
So it is written team 1. I mean, we're coming from 3 to 1, isn't it?
Yeah, it's 3 to 1.
So you can give this question to team 3.
3. That's fine. Yeah. A 12-year-old male presented with cyanosis. Have a look at the ECG properly.
Jay, you want to show the X-ray also?
No, this is X-ray, madam. Yeah, both together, madam. I think in 3 clinical scenarios.
Right.
ECG, X-ray, ECG, X-ray for all 3.
Okay.
Yeah.
Team 3. It's easy.
It's very easy.
But you'll have to sort of give an, a detailed explanation since it's easy.
Team 3 can unmute, please. You want to see the ECG again, or you're okay?
Yes, yes, ma'am.
Can we see the ECG one more time?
So it's a 12-lead ECG with.
No, we don't want you to interpret.
Yeah,
we want you to give a diagnosis now.
Don't read it. You just look at it and look at the X-ray and give your diagnosis.
It is fine. ECG is fine.
X-ray,
X-ray, ma'am.
You want X-ray?
Yes.
Yeah.
Pulmonary AB malformation. Likely pulmonary AB malformation.
Yes.
Okay. Very good. How would you confirm it?
Most bubble contrast echo will be confirmed.
Bubble contrast echo. What kind of pulmonary malformation you think this one is? You know the various types of AV malformations?
Don't know.
Team B, team 2 or team 1 can answer maybe?
Yeah, team 2, I guess.
Team 2, sir, team 2.
If you want to answer team 2 or team 1, I don't think we are giving any bonus marks, but you could just answer the question if you want.
Ma'am, this type 1, which is non-familial, and type 2 is familial. It will be associated with visceral and cutaneous AV malformations, like in HC.
I think some audio issues with you.
Yeah, I think team Srichitra needs to fix their audio issues, please, quickly, because we're having a lot of trouble hearing you.
There are 2 types of PAVMs. Hello?
Yes, we can hear you now. Yeah.
So type 1 is the non-familial type, and type 2 is the one associated with HHT.
Okay. So what is team 3 back? What would you do for this patient next? You've done the confirmation by bubble contrast. What do you want to do next?
CT for better characterization of.
With what in mind?
To rule out other causes like Abernethy or.
No, I think that's not a correct answer. When you see this, would you want to think of Abernethy? What kind of malformation you have for Abernethy?
Do you get such localized malformations in Abernethy?
No. There we get diffuse AVMs.
So you want to treat this patient, don't you?
Embolized basically for we will plan the embolization of this AVM.
So you would do a CT to find out the feeders.
Yes,
how big is the what kind of device you should use for those reasons. And of course, if there are others also, because it may be one big and there could be other smaller ones also. Dr. Jairamnath, you want to add anything?
Oh, nothing. So that's quite good, but the CT is mandatory nowadays. In the olden days, probably over 2 decades ago, not doing, but the CT is mandatory, as Madam said, that to plan this closure of these things with either any of the devices, coils we don't use often nowadays, unless it's a very small fistula. A lot of devices are available. We need to have the CT imaging. It's mandatory and it's a must. It will give a lot of information.
Okay, excellent. Let's go on to the next example. Very good one, really. Very nice example.
So next, team 2, I think.
Yes.
Yes, sir. Team 2.
Have a look at the ECG properly. 5-year-old male, essentially asymptomatic, with a saturation of 92%. I'll come back to the ECG if you want. Just take some time. The ECG and the X-ray, which I'm going to show, belong to the same patient. You want to see the ECG once again?
Please unmute yourself.
Team 2.
Yes, sir. The ECG showed sinus rhythm with a right axis deviation with RVH and right atrial enlargement, and with reverse progression of the R waves. And also we in the V3R and V4R, there are prominent R waves with a small Q in V4R, which is suggestive of a right ventricular volume overload also. And
X-ray.
X-rays are showing cytosolitis with levocardia, with cardiomegaly with a CTR of around 63%, with dilated main and right pulmonary arteries, with normal pulmonary blood flow. Sorry, with slightly increased pulmonary blood flow.
Can you make a diagnosis with everything, with both of them together? Or some differential diagnosis?
Yes.
No, you rightly said there is a cardiomegaly, no question about that.
Although
And
that 63% is difficult to understand, how he came at 63, but that I agree with you.
One can be, sir, it can be VHD with PH, as manifested by mild cardiomegaly with increased pulmonary blood flow and dilated pulmonary arteries, along with cases of and with so it will be AHD with PH, sir. It is
do you think main pulmonary arteries also dilated?
Yes, ma'am.
No, I think you look
because,
again.
I mean, Dr. Jairangnath can actually point that in the segment of main pulmonary artery, there is actually no prominence. Prominence is beyond that. So that is like left pulmonary artery. You can see them, yeah, exactly. You can see the margin of the pulmonary artery segment very well here, which is not prominent.
That is the give. That is the most important point that Madam is pointing out. That is the key point.
And also, when you say pulmonary arterial hypertension, either in the presence of AST or a VST, what's happening to the lateral? You yourself said it's a normal flow. I mean, relatively normal thing or increased thing.
Sir, it can be.
Really, is it really looks like the right pulmonary artery is dilated as a consequence of the severe pH?
Sir, it can also be pinked off, sir, with a RV type of PEX with RVH and with non-dilated MPA and dilated RPA and LPA.
Which is TOF with?
TOF with?
Absent.
Yes, you're right.
Yes, you're right.
You get absent pulmonary valve.
See, this kind of pulmonary artery dilatation, you will never get pulmonary arterial hypertension also. Look at the RPA. It's almost going up. You know, it's so huge. So that is unlike PAH. This is abnormal dilated right pulmonary artery, which is often seen with TOF absent pulmonary valve because of the deficiency of its wall. strength. So this is very peculiar to TOF absent pulmonary valve. I don't know about the ECG, but the X-ray is quite typical of TOF absent pulmonary valve. And Dr. Sanjay Sharma is here to support me.
Sir, you can't remain silent for so long, sir.
This is very interesting. So this young team, you have gone from one end of the extreme to the other end. So you have said VSD PH at one end, and now you are saying tetralogy with absent pulmonary valve. Do you realize? So what is the key difference between these two X-rays? So suppose this was a VSD PH. How do you? Yeah, tell me. So you have a dilated pulmonary arteries. You missed the point that the MPA is not dilated. There is peripheral pruning, or there is peripheral oligemia, but that's not important. What is important? Unfortunately, you can't see my arrow. So in patients in chest X-ray, how do you localize shunts? Whether it is right to left shunt or left to right shunt. What is the key factor which you see in every X-ray?
So the pulmonary blood flow, sir.
Oh, pulmonary, see, remember, for classifying these shunts, pulmonary arteries of no consequence. That is just to establish whether it is increased flow or decreased flow. How do you classify these shunts? Intracardiac, extracardiac, tetralogy, or is differential diagnosis or something else? What is that key factor? One factor in chest radiograph in all congenital heart diseases. What is that?
So the amount of.
That's the aorta. Look at the aorta here. Do you see prominent ascending aorta? Is this the aorta of an intracardiac shunt? Is it a normal aorta? Is it large aorta? Large aorta. So that's the key point. So if it were a VSDPH, you would have seen a normal aorta. Here is a large aorta with absent main pulmonary artery, but dilated peripheral pulmonary arteries and peripheral oligemia. There is no differential diagnosis. This is a spotter, actually. You understand what I'm trying to tell you now? All times when you see the chest radiograph, look at the aorta. Normal, is it enlarged? If it is normal with an increased flow, there is a differential diagnosis which is different. With a large aorta with increased flow, it's a differential diagnosis which is different. Same way in a true patient, normal aorta, valvular pulmonic stenosis, abstinence anomaly, a different set of differential diagnosis. Large aorta, tetralogy, tricuspid atresia, VSDPS, single ventricle PS, a different set of diagnosis. So you understand the learning point here is the aorta. Look at the aorta. Yes, if you look at the aorta, you will never make a mistake.
Okay, sir.
Sorry to interject. I just could not.
No, you didn't interject at all, sir. It's appropriate. Those comments are valuable.
Absolutely. Yeah.
And you're free to interject at any time, sir.
So shall we move on to the next?
Yes, please.
So this is a very classic absent pulmonary valve X-ray. Okay, so the team 1 now. Have a look at the X-ray, sorry, ECG. There is some artifact there. Don't go by that. On the left side. This is artifact. Don't worry about that.
And Jay, they are from your own hospital, so I'm assuming they haven't had the opportunity.
Completely kept secret.
So Jayadeva team.
Jayadeva team.
You want to see the ECG once again before you go back to the X-ray, and then
yes, sir.
ECG, have a look at it. What is there? There is a QR. There's the right axis deviation, tall P. Some kind of an RV strain. So nothing much here. Dominant RV forces.
Okay.
Now you just read the X-ray and possibilities. Read the X-ray.
Please unmute yourself.
Please unmute.
You have to unmute.
No, that's they're muting to discuss amongst each other. So that's all right. Go ahead.
ECG is showing dilated enlargement with RVH with RV strain, and X-ray showing cardiomegaly with Right atrial enlargement and RV type of effects with MPA enlarged, dilated. Decreased pulmonary blood flow, sir. Our probable diagnosis is pulmonary stenosis with tricuspid regurgitations.
Anything you want to add to your diagnosis? I agree with your diagnosis, but anything else, since there is so much cardiomegaly, not just RA, the whole heart is very big. It's not just cardiomegaly, it is massive cardiomegaly actually. So something else which might just sort of give a little bit extra importance to the diagnosis.
You're almost there, but you have to tell me more specific.
Why there is so much cardiomegaly, you think? It is a severe obstructive lesion. You said pulmonary stenosis. I don't know. You probably said severe, and you also said TR. Is it one more thing you want to add to your diagnosis? Something which brings in the emergency of the situation.
Yes.
See, whenever we talk of obstructive lesion, automatically we talk of ventricular function with it. It's automatic. It should come with it. So do you think there is some RV dysfunction, or you are not sure?
Yeah, yes, the RV dysfunction.
Likely.
So RV dysfunction is there or not? Because
is it likely or unlikely?
Likely.
It is important because these are the cases where you must relieve their obstruction immediately. If you don't think about RV dysfunction, you will not think about the urgency of the situation.
Okay, Jay, you can show the answer and then we can go on to the
answer
audience.
is pulmonary stenosis with regurgitated severe RV dysfunction, right heart failure. Causing right heart failure means there is a severe RV dysfunction. This is a very classically X-ray with the intact ventricular septum with a isolated critical pulmonary stenosis with a severe RV dysfunction. You have the X-ray like this, so you need to relieve that as quickly as possible.
This is the subset where you have to relieve a little carefully, isn't it? In a graded fashion. We've had pulmonary edemas happen. I think we have to just watch it, and this is
so
a very dangerous subset.
So you're in a hurry. You said severe TR. How do you approach these cases? You know that there is a valvular pulmonary stenosis. Any thought on that?
In the cath lab, how do you approach?
Cath lab, severe TR, you can't afford to waste time. You have to go immediately do something.
Yes, sir. Emergency PBV to be done, sir. It's valvular
which approach?
How do you want to do it?
What are the likely problems you are going to face in this particular patient, and you should be ready for it?
So you have to cross the valve.
Because of TR, the catheter will be being pushed backwards. We cannot enter from the RA to the RV properly, ma'am, because of the severe TR jet.
So how do you overcome that? That's what he's hinting at. Dr. Jayaranganath is asking you again and again. How do you overcome that challenge of TR pushing out your catheter?
We can go from the upper limb axis rather than the lower limb axis.
Not upper limb, but jugular axis.
From jugular axis. Jugular axis, we can go from above downwards so that it passes through the valve easily.
Okay. Okay. So shall we go on to the audience?
Audience round, please.
ECG of a 5-year-old child with severe pulmonary hypertension, you can say. Class 2 to 3 symptoms for last 2-3 years. Normal saturation, of course. This is the X-ray. Shall we go to the answers, KK, or?
Yeah, sure. We can.
We'll launch the poll. We'll launch the poll for the audience. So you can just show them the options.
No, options are.
No, sir, go to the blank slide. So the poll is already there, sir.
Oh, where I can't see it.
Vishnu, can you just launch the poll that will have the options actually?
Yeah, sure.
It's a tough one.
Dr. Jarena, can you show the ECG one more time? Just to, because it's quite a divided house.
Yeah.
No, I think both ECG and X-ray are very good. Vishnu, can you close that? I'll go back to the X-ray.
So is there any evidence of left atrial enlargement?
None.
Can we see the options again? The 4 options that we had? Or the poll? Yeah.
Oh, it's unlikely juvenile mitral stenosis.
There is no left, there is right ventricular hypertrophy, but no left atrial enlargement in the ECG.
There's no
X-ray also,
there is no left atrial enlargement. Yeah.
X-ray also, there is no left atrial enlargement.
Yes, yes, madam. So that is out. Mitral stenosis is out. So
I think we should have Dr. Sanjeev Sharma just comment on this.
Yeah.
The possibilities. I think we can have some insights on this possibility.
Yeah, I think mitral stenosis and pulmonary stenosis are out. Now the question is between pulmonary venous and PD Eisenmenger. I mean, there is severe pulmonary arterial hypertension for sure, but what is the cause?
Dr. Sanjeev, this is not very straightforward.
The cyanosis is not there. Saturation is mentioned to be normal. First one. So unlikely to be with PDA with Eisenmenger. And second thing, if it is a PDA with Eisenmenger, the aortic, because if it is a PDA with Eisenmenger, the aortic shadow will also be
enlarged. Dr. Sanjeev, I think we're not able to access him at this point.
We do see some PVH in the X-ray. Dr. Jarena can probably tell.
Dr. Sanjeev has come. He's come online.
Okay.
So
Sanjeev, sir.
Results. Then only they can see the X-ray.
You can move the pole. Actually, you can pick up that window and move it aside. Yeah. Dr. Sanjeev,
he is muted. Dr. Sharma, you're muted.
No, I'm muted. I'm trying to actually, there is some signal challenge here. I got logged out. Yeah, what was the issue? Sorry. I was struggling for last many minutes trying to reconnect. Yeah.
No, I think it's terrific. Now that the X-ray has just come on, I want you to interpret this, sir. And give
very
you
interesting. Okay.
So that you can have a totally unbiased view of this X-ray.
Yeah. So what we have here, so I heard the ECG interpretation a while ago about no evidence of LA enlargement, but you do see a double density here very well. So, but at the same time, you don't see splaying of carina.
Yes.
So,
Dr. Sanjeev, do you think this is that double densities LA is rather high for LA?
No, I am not saying that. What I said was that there is a double density, but there is no splaying of the carina.
Okay.
So this is likely a differential diagnosis of LA enlargement, primarily. Also, we don't see any appendage enlargement, but we see only a double density here. So we have to the carinal angle is less than 90. So likely LA is not enlarged. This is the dilated pulmonary confluence of pulmonary veins, which is at the root of it. So the shape of it doesn't suggest so, because usually when you have this confluence of pulmonary veins producing a double density, the lower margin of it is relatively straight. Or
yes.
This is not the way it bulges in this manner.
Yes.
Is it a carinal group of lymph nodes which is enlarged? Well, that's the other differential diagnosis that you have to think about. But again, there is no lobulation, so I wouldn't really keep that as a differential diagnosis. I would, if I have to choose between the various causes producing double density, LA would still remain very much in the list. There is also what we have here is this prominent pulmonary conus and evidence of PAH. Though I don't see the right costophrenic angle very well. Were there septal lines or not? I don't really know. I can't see this very well.
Slightly overexposed.
Yeah, it's overexposed film. So we really can't say, but there is some lung lesion in the right upper lobe here. There was a question whether it is PDA or not. So the aorta is not dilated as much as it should be in a PDA, but there is a disproportionate PAH here. So I would not really exclude a PDA as a potential differential diagnosis.
I think pulmonary venous. I think one of the differential diagnoses was pulmonary venous obstruction.
Only venous obstruction again would produce, but then what is important here is that we should be seeing the basis very well, and this film is overexposed actually for interpreting for pulmonary venous hypertension. I don't see any curly lines. Putting all these together with such a disproportionate presence of pulmonary arterial hypertension and a double density here, PDA would be a possibility here.
I think it's a very illustrative X-ray, sir. It just shows that we can't get too precise on these X-rays. It just illustrates how we can describe the physiology as best as we can. So there you can tell us what was found in this patient.
So can it be co-triatriatum?
It can be. It can be.
That can explain this double density.
It can be. That's a differential diagnosis. That is one of the causes of a disproportionate PAH.
Yes, and that explains known enlargement of LA appendage as well.
Yes.
Also, that will also explain a possibility of some pulmonary edema in some areas.
Okay, I think Jay, you need to tell us what it is.
No, in this case of all four pulmonary veins were stenosed. Left more than right upper lobe pulmonary veins or hardly in the CT was not even, there was no lumen at all, completely obstructed, almost like a total occlusion. Right lower left pulmonary vein was stenosed, but when we did a cath, it was not much of stenosis. It was a significant stenosis was not there. And the left, both upper and lower, very tight stenosis, thread-like. This is the isolated pulmonary vein stenosis of all the four veins. And the PA pressure was around 70, aortic pressure was around 85 or 90. This child was presented with a severe pulmonary arterial hypertension with a pulmonary stenosis. So we dilated the left pulmonary veins and we put a stents there because there was a lot of recoil happening. Renal stents we put it. Right upper, we did not even try because CT was not showing anything, not lumen at all. Right lower pulmonary veins, we did not do anything. Because it is significant, the hemodynamically it is not significant on the cap table. There are only less than 2 mm gradient. That's it, KK.
Thank you so much. It's a
That's very, very interesting. So, just a learning point here for the student. So when should you suspect pulmonary vein thrombosis or a veno-occlusive disease in this setting in a chest radiograph? When you see persistent pleural effusion, unexplained persistent pleural effusion in the setting of pulmonary venous hypertension. That's something you should always remember. Though we don't see the claustrophrenic angles here, that's a different story. But that's something you should remember.
So one quick question, sir. How do you explain the double density now?
We can't. Jay, we cannot explain the.
We cannot explain.
I would think it is LA.
No, Rama, the LA was echo-wise. LA was not very big, sir. It's a normal size LA. In fact, I was a bit worried. The RA was big and LA was not very big. But carefully, we did a transeptal puncture. There was no issue. LA is not at all big, sir.
Okay. Very interesting.
We don't know why that shadow is there. So that's a mystery, and I'm glad that this question didn't go to any of the teams. So let's go on to the next round, which is again round 3, and team 1 will take it, Jaydeva. And this time, I think Dr. Navneeta will be presenting the clinical scenarios. Navneeta, are the slides visible? Are the slides to be shared by you, Navneeta, or should I share it?
I can share them, sir.
That will be better if you share, because that way you can actually control the situation well. Let's go on to slideshow mode. It's visible. Yeah, it's visible. It's visible.
Okay. Shall I start?
Okay. So can you?
Yeah. Good evening, everyone. So this round is going to be based on clinical scenarios. So the first question is going to team 1, if I understand.
Yes, ma'am.
So this is a newborn. Born in hospital. This is a tertiary center on day 3 of life after initial stabilization. When the baby presented, baby had intense cyanosis, saturated around 50 to 60% in all 4 limbs. Examination: F1 normal, F2 single, no murmurs, tachypneic, listless, lethargic, with left focal seizures, cool extremities, hypotension. There was an IV line in the left upper limb. The baby did have an echo report, which was a brief screening echo done by an adult cardiologist, which was reported as severe global LV dysfunction and moderate MR. The X-ray which is shown is the X-ray on admission. And I will also be showing the ECG of this patient. So this was the ECG on admission. So there are 2 questions. What is the likely underlying diagnosis? And can you explain the ECG and the clinical status?
I should correct by saying what is the likely explanation of the ECG and current clinical status. I'm sorry, that is an error that I have made, Navneeta. What is the likely explanation in this?
Yeah. That is the X-ray and that is the ECG.
Okay. All yours, Jaydeva.
Sir, this is a 3-day-old neonate which was having who is having a saturation of 50 to 60%, and screening echo they have mentioned that there is severe global LV dysfunction, moderate MR. On chest X-ray, it is a poorly exposed, overexposed film with cardiomegaly with pulmonary venous hypertension very evidently seen on this, and enlarged right atrium with a cardiothoracic ratio of more than 60. Suggestive of LV dysfunction. And in the ECG which ma'am had shown, there are ST elevations which are seen in lead 1, V4 to V6 with Q waves in lead 1.
Going back to the X-ray, can you look at the shape of the heart and say something?
Oh my God, you're given such a nice hint you're giving, Navneeta. Good, good. It's okay. That's fine. That's okay. We'll give the hint. But then, anyway, go back. Jaydeva, you had gone on the wrong track, but we'll take you. We'll see how far you go on that track. So let's have you interpret that ECG in the context of what you had said, cardiomegaly, PVH, and all. You had said that. Let's see the ECG again and tell us Because there is a course correction you can make now, but you can please tell us what are you thinking of? What do you find on the ECG? Can you give the findings?
LV, sir, sinus tachycardia with Q waves, with absent Q waves in V5, V6, and LVH, sir.
Okay.
V5, V6 don't have Q waves, so it is.
I'd like you to see the lead 1, AVL, V2, V3, V4, V5, V6. Is something not striking you in the context of somebody who has LV dysfunction? And then you go back to the clinical picture. So we can just go back, put everything together. So can you go back one slide? Now, what do you see? He's tachypnic, listless, lethargic. He's had left focal seizures. These last 4 lines, last 4 or 5 lines are very critical to your interpretation. I'm glad that you're making these mistakes because this will really illustrate the challenges here. Sorry, Dr. Taragan, I'm stealing your thunder. I think you're supposed to moderate
we have
this.
A differential.
Yeah, go ahead. Please give us your differential diagnosis.
So one differential we are thinking is obstructed TAPVC.
Okay.
One more in view of ECG changes and echo showing severe global LV dysfunction with moderate MR, we are thinking L kappa, sir.
How will you explain 50% saturation in L kappa?
That was one.
How will you explain intense cyanosis in L kappa?
KK, I'm so sorry to interrupt here. So these young ladies, go back to this X-ray and tell me where is the pulmonary artery segment? Do you see the pulmonary artery segment in this X-ray?
No, sir. Pulmonary artery appears
Is
concave
this
actually.
pulmonary venous hypertension or is this increased flow?
It is a pulmonary venous hypertension in the peripheries. It looks like there are curly lines.
Are the lower vessels bigger or the upper vessels bigger?
Upper vessels.
See the right side. It's more obvious on the right.
Look at the right side.
Right side and lower vessels. Lower vessels are only bigger.
So is this increased flow, decreased flow? Or increased flow or pulmonary venous hypertension? Is this pulmonary edema? So you said obstructed TAPVC. Do you see any pleural effusions? Do you see any whitening of lungs?
No.
In the periphery?
No, sir.
No. Then, so what is striking here is an increased flow with absent pulmonary artery segment. Okay. What's your diagnosis in a newborn?
What's the most likely diagnosis?
Pulmonary atresia.
Pulmonary atresia?
So, why is there increased flow?
Pulmonary atresia?
If you can draw a line along the cardiac silhouette, what does it look like? No?
Agon side
The saturation in background.
So where do you get agon side?
TGS.
Okay, now let's see the ECG. Now tell me, how do you put it all together? I've given you clues on the.
So there is a learning point there. In the chest radiograph, whenever you see pulmonary artery segment non its normal position and increased flow, this is a classical DTJ.
So now you tell us why you have these ECG changes, extensive STT changes that you're seeing in V1. There is, in lead 1, lead AVL, that's ST elevation. There is ST elevation across chest leads. Why do you see? How do you explain this in a transposition child who also is happening to have seizures? Okay, the previous slide. Navneeta?
Yeah, on.
Yeah, so can you look at the penultimate point that you are putting out there? This is deliberately done to show you IV line in situ in the left upper limb. So this is something that happens, isn't it, in units, and people don't realize it. what could have happened? And you need to know this because you can prevent it from happening the next time. I think we can give the answer away, Navneeta, and then we can move on to.
That was indeed a tough one, the two processes simultaneously. So essentially, the reasons for the STD changes were, most likely in the setting air embolism, and the underlying diagnosis was PGA. So BAS was done, and after the saturation improved, the baby could be extubated, and the renal function as well as the neurological status as well as the cardiac output, the hypertension part improved, and the ECG also settled. So the explanation most likely is from an air embolism, which is caused the whole picture. And of course, it is an entirely like two different issues with the patient, PGA underlying, and on top of that, an air embolism. So the take-home point is that any congenital heart disease with a right-left shunt, it's important to make sure that air is not flushed into the IV lines.
Sorry, this was a little hard, but you shouldn't have missed transposition. But it's also important then that to also recognize how serious air embolism can be, because the amount of air that you need in a baby of this size is very little on the right side. And it just goes straight to the coronaries, it goes to the brain, it goes to every other structure. So it's very important to recognize that. And can we go on to the next question, Navneeta? It's,
yeah. So this is question number 2 for team 2. So among these options A, B, C, and D, can you choose the picture of the child who's most likely to be associated with a cardiac diagnosis of a ventricular septal defect with a type B arch interruption?
Ma'am, it will be associated with the Dyegeorge syndrome,
that's right.
Yeah. So which is the picture you want to choose for Dyegeorge? A, B, C, or D?
D, sir. D for
D. You got that right, I think. Yes.
Right.
Very good. But for the sake of, we'll push you a little bit. Now you identify C for us. What is C? I mean, you've got your points, but you can just score some, impress everyone with your clinical acumen by telling us what is C. Which syndrome is C? Unmute yourself, please.
Not sure.
Not sure. Okay. Okay. Can we ask the other teams to have a go at the other syndromes that are there?
C maybe Williams.
Very good. Very, very good. And then B, if anyone wants to have a go at that.
B is Noonan.
Very good. Excellent. Now the hard one, A. A is the difficult one. I don't blame you if you don't get it.
SS syndrome is.
Okay, so I think we'll give you the answers, and Dr. Navneeta will explain.
Yeah. So the other three you got right, and the A is Chart syndrome, in which you can get microphthalmia, microcornea, facial asymmetry, deficiency of this depressor anguli oris, which is seen in that abnormal lips. And Chart is most commonly associated with VSD, CHOP. Noonan, as we all know, pulmonary stenosis and hypertrophic cardiomyopathy, and Williams, supravalvular AS, peripheral PS, and Dyegeorge, as you mentioned, conotruncal anomalies, and particularly type B interruption of the arch. So we'll go to the next question.
Excellent. Well done, Sri Chitra.
This is for team 3.
All India Institute.
So here's a patient who has undergone a bidirectional Glenn shunt at 8 months of age for single ventricular physiology. Now he presents at 8 years with progressive desaturation. SpO2 of 68%, hemoglobin 16.5, S1 normal, S2 single, no murmurs, and underlying anatomy on the echoes, double inlet left ventricle, good sized branch PAs, good ventricular function, unobstructed gland, and no AV valve regurgitation. So essentially, this is the X-ray at presentation.
Following BD Glenn, worsening cyanosis, the common reason is diffuse pulmonary AV malformation.
So there is relative anemia also, so maybe.
I think 16.5 isn't relative anemia.
With saturation of 68.
Mostly development of pulmonary AV malformations following BD.
Okay.
So, you've got the answer, but then we'll give you the questions. So you can fine tune the question anyways. So we'll show you the question next slide.
Yeah. So what would be your next step?
Saline contrast echo from contrast.
So which route? Yes.
Upper limb.
Yes, left upper limb. Why left? Why not right?
Mostly if associated with if it is associated with LSVC.
Yes, very good, very good.
So we can go to the audience.
Yeah. No. Next question. Actually, we've just got that slide with the differential diagnosis of desaturation after Glenn.
Oh,
so
yeah,
I thought we can just go through that whole checklist, which tells you, how many conditions you can actually pick up in these situations. When you see, when you have a desaturation after Glenn, you see how many conditions that you can pick up. So if you see this, previous. So if you see this, if you give a left-sided contrast injection, you will pick up veno-venous collaterals, persistent LSVC, and of course you'll pick up AV malformations also. You could have older age, which reduces the cerebral blood flow, obstructed anastomosis, elevated LA or pulmonary venous pressure, high PVR, branch PA narrowing, pulmonary AVMs, anemia, even a certain degree of anemia, not 16.5, but let's say if the patient had 11 or 12 hemoglobin, then can produce marked desaturation by oxygen extraction and gives you desaturated blood that goes into the aorta. And then ventricular dysfunction with cardiac output reduced, that also will do the same thing. So you have a long list of conditions. And the corollary is, if you have good saturation in a Glenn, all this is often unlikely. So that's a very healthy sign. So we'll go to the audience round, I think.
Oh. So which of the following conditions is most likely to be inoperable? Complete AV septal defect in a 10-month-old infant with down and a resting saturation of 92%. Transposition unrestive VFD, 4-month-old infant, resting saturation 81%. Large VFD, supramitral ring, severe pulmonary venous hypertension, saturation 78% in a 3-year-old. Or a large AFD in an 18-year-old with a PA mean pressure of 56 and resting saturation of 91%.
So once the answers have come in, Dr. Taragan, I would like your comments on this set of possibilities and the way you would analyze it. It will be useful for the audience to listen to it. Once we get the answers in, I think we'll wait for another 10 seconds. The audience seems to have got it right. But Dr. Targam, can you just step in and discuss these 4 possibilities? Not able to see Dr. Targam.
So you have to unmute.
Yeah, sorry.
So sorry. I think let's look at the first choice, complete AV septal defect in a 10-month-old with, I think it's Downs, isn't it? Yes. Anyway, at 10 months, really no shunt lesion can be called inoperable, except in the fact that Down syndrome has 2 other issues. One, of course, is they have a higher incidence of pulmonary dysplasia. And of course, some of the desaturation can be due to obstructive airway. So these are the 2 reasons which you have to consider. But I think the second one, obviously, it doesn't matter. You can always correct it surgically. The first one is the pulmonary dysplasia, which is more common in Down syndrome, and hence their outcome may not be as good. But still, at 10 months, I would give him a chance. Transposition with unrestricted VSD in a 4-month-old said anyway, and transposition and with unrestricted VSD is the one which actually allows survival, because not only the pulmonary flow is good, the intermixing at the ventricular septal defect is good. At 4 months, it may be too early to say that this transposition child has a pulmonary vascular disease. So I would still give him a chance for correction. A large VSD with supramitral ring, of course, it's easy that any obstruction down the pulmonary vein or a mitral ring or a common, portal atria, mitral stenosis, whatever it is, any pulmonary obstruction would make this patient always a pulmonary venous hypertension related pulmonary artery hypertension. So you have to relieve the obstruction downstream, reassess, or at a young age, you could actually sort of correct the obstruction as well as correct the lesion. So I think this patient is at what age? What is the age of this patient?
3-year-old.
3-year-old. I think it could be done in one stage, that it can be operated. Whatever the pulmonary venous obstruction can be corrected, and the VSD. Obviously, for a large ASD at the age of 18, it's not the size of the ASD that is important. It's the pulmonary vascular resistance. If it is more than 5 units, and if it does not come below 5 Wood units with so-called vasodilator acute vascular challenge, it's inoperable. If it does come below the 5 Wood units with vasodilator challenge, it may be operable perforation. I mean, I think that's good. So I think that D would be the one which goes just outside the operability, in view of the PA pressures being the mean pressures being very large. The shunt, of course, is not mentioned. But see, there's also something that resting saturation being low in an ASD, VSD, or PDA. Certainly, exercise-induced desaturation is contraindication for surgery in VSD and PDA. And exercise-induced desaturation in ASD also is a contraindication. But resting desaturation in ASD can be for many reasons, including a coronary sinus type of VSD, some SVC straggling, some IVC streaming, so or a TR they're going into the LA. So a resting saturation at 91 cannot actually be by itself the contraindication for surgery, but exercise-induced desaturation for both ASD, VSD, and PDA. More for ASD and PDA would be a contraindication for it. This would be my how I suppose.
That's very, very, very useful. So thank you.
Thank you.
We'll go on to the next round, and we'll start in reverse order again. Team 3 will be the first. And we'll ask Dr. Arun Gopalakrishnan to share his slides, and we're doing echo. We are on schedule to finish 5 rounds by 8:30, so we may not be able to do the bonus round, but I think it's been fantastic so far. So Arun, can you please share your screen?
Yes, sir. Go to the first question. So this will be to team 3, isn't it, sir?
Yes, yes.
Okay. So I'm showing a single echo loop. This is a 19-year-old patient with class 2 dyspnea on exertion. Could we have a complete diagnosis from or interpret? Sir, you could.
Yeah, requesting the teams to interpret this and give a complete diagnosis. We are keeping it simple. We're not asking any twisted questions. We're just asking you to. So this is All India Institute. Give you a diagnosis.
Most like post-operative, post-sending.
Post-sending with
atrial switch.
Atrial switch. That's one part of the answer. You want to complete your diagnosis. Is there anything else that you want to identify?
Stenosis. Sir, there is some turbulence. So.
Okay. Not only is there turbulence, how much is that space out there? Can you give a diagnosis, complete diagnosis? You're right that it is post-sending, but what is associated with this? What is the striking abnormality that you see in this post-sending patient, which you should be able to alert? You said there is turbulence, and I can see two turbulent jets, one in the systemic venous baffle and one in the pulmonary venous baffle.
Yes, sir. Pulmonary venous stenosis post-operative.
Pulmonary venous baffle occlusion, not vein stenosis, but there is a stenosis at the baffle, at the junction. So can you, Arun, can you just put your arrow and point out so that it's visible to others? Because my arrow will not be visible to everybody.
Is this visible?
Yeah, this is visible. Perfect. So that finger is pointing there. You can see that, not only is there turbulence, but also there is very little space out there. You've got to, in fact, have much more space out there. So there is narrowing. And of course, there is turbulence. So this results in pulmonary venous hypertension. And you can see that the upstream chamber is somewhat dilated, which is the pulmonary venous baffle, that area that collects the pulmonary veins, that is somewhat dilated. And individual pulmonary veins are also prominent. You can see at least the left lower pulmonary vein is seen, they're very prominent. So this is something which will produce what? Pulmonary venous hypertension, pulmonary arterial hypertension. Okay, I think they've done very well. So can we
go to the next question, sir?
Yeah, please. So this is team 2.
This is a 8-year-old child with a cardiac murmur. Again, a single loop.
Yeah, and you have to give all the findings, all your observations. Take your time, take some time, and then give everything together. The team at Sri Chitra, which I hopefully hasn't seen this loops.
So this is a transesophageal echo at 117 degrees, which is showing the LA, mitral valve, LV, LVOT, and the aorta. So we can find that there's a turbulence from the LVOT to the aorta, and it looks like there's a aortic membrane, aortic membrane, which is causing the LVOT obstruction.
That's excellent. One or two more points that Saurabh had picked up, and when we had discussed this pre-op, which if you want to have a go, any other things that you would expect to see in this situation?
Sir, coronaries, if you are able to see, but it is
no, not coronaries.
Yes,
coronaries is unlikely. So there is left ventricular hypertrophy that you can see out there, which is significant. You can see the wall of the left ventricle, which is very, very significant, septal wall. And see the QRS, which is there on the ECG, is also having a fairly significant increase in
widening.
Yes. So these are the points that Saurabh had pointed out, but you got it all right, man. You've got a perfect answer to this question. It's easier than what we expected. I think these guys are all very good at echoes. So we go on to the next question.
It's actually post it's a recurrence actually. So probably that is the reason why this area is so hypertrophic and this area QRS is wide, and here this area is
Surprisingly, there is no AR, despite the membrane being very close to the aortic valve, almost 2 millimeters.
That's a very good observation, sir. There is always AR in these circumstances, but this child doesn't have AR. That's correct. Completely.
That's nice.
Very nice. Okay. Well done. And the next question, that is to Jayadeva. Team one.
Team one. This again a single echo loop, 4-month-old child with failure to thrive and mild cyanosis.
We'll give you a little more time because this is a more extensive loop than the others, and we'll want you to come up with a complete diagnosis. You don't need to, even if you can analyze it, that's great. If you analyze it simultaneously, but you can come up with a complete diagnosis.
Sir, this is mesocardia, sir. Mesocardia with
start with the view. You can say which view it is.
Sir, it is subcostal inverted lineage, sir. It is showing mesocardia with intact interatrial septum with an inlet VSD and AV discordance, sir, with the right-sided ventricle giving rise to one great vessel which is not branching, probably the aorta, and the left-sided ventricle is giving rise to an artery which is branching, a pulmonary. So think of CCTGs.
So complete diagnosis now. Your analysis has been very good, but now I want you to give you a complete diagnosis.
CCTGA with inlet VS mesocardia CCTGA with inlet VSD, sir. There are no.
You're making one consistent mistake by calling this inlet VSD. Pay attention. This VSD is not inlet VSD. This is when you see the inlet septum. Wait. Before you start, the inlet. When you see the inlet septum, you're actually seeing a lower attachment of the tricuspid valve, the left-sided tricuspid. You see that offsetting epsteinoid malformation. That time you're not seeing the VSD. You're seeing the VSD only when you profile the great arteries. So you see that? So the VSD is a conoventricular or a
conoventricular
PMVSD. It is not located in the inlet septum. It's very important to recognize that. But everything else that you said was right, and the only thing that you missed perhaps was the fact that the mitral valve, the tricuspid valve, is a little lower
and lower down
in that sense. But I think these are all acceptable errors, and we'll give you full marks because you got the analysis perfect. Excellent. So clearly the strength of all the teams is in echo. And they're doing a lot of it, looks like. So let's do the audience round.
Yeah. So again, one single loop. Which of the following is the most likely in this 12-year-old boy with class 2 dyspnea? 4 possibilities which I mentioned. Again, only one loop.
You can just see the loop. You can zoom so that people have time to.
You can move the screen. Yeah, you've got the answers, but we can move the screen. What happens is that you have to pick up that window and get it out of the way. Looks like the audience has done a very good job here. But I think I'll have Arun explain why it is aorta LV tunnel, because that very specific explanation that he gave is important. So Arun, please explain to the audience why, and your fingers going right there. Yeah.
Yes. Here, actually, we can see there is a red. This is a parasternal long axis view. This is the left ventricle. This is the LV outflow tract, the aortic valve, and this is the right ventricle, interventricular septum. So here we can see the regurgitation starts at this point. There is a red jet that is directed relatively anteriorly, that is towards the junction of the annulus and the interventricular septum, and then all along the anterior margin of the aortic, the right coronary cusp, it comes down, and then the jet is directed posteriorly. So this actually tells that this is not arising from the point of coaptation of the leaflets, which is at this point. If the posterior directed jet comes at this from the center of the point of coaptation, it could be a regurgitation seen in a bicuspid aortic valve, but this is not usually seen. This jet is directed anteriorly and then curving around. So that is usually seen in a LV to aorta tunnel.
Excellent. In the interest of time, we'll wind up this rounds, and now we'll go on to, so you can stop sharing and ask Saurabh to share his screen. Saurabh, we apologize for being a little late, but I think we'll let you do your full round because it's a very important round. And I think we may not be able to do what Rama was planning to do, but that's still probably okay.
Thank you so much, sir. And
Dr. Sanjeev will moderate here.
Sir, am I audible and my screen is visible, sir?
Yes, yes.
So since it is on CT, and I think that CT is not commonly seen by cardiology residents, so I'll just show one axial section, how we kind of interpret that. And then I'll go on to the three, laying down the foundation, how it should be analyzed in a cardiology manner. I mean, radiologists see, I request sir to give inputs if there are any. So I'll go to this one young adult CT who had idiopathic PH, and I'll just run it. And as we see in echo, we go take the abdominal cut, and then we start from below upwards, and we keep seeing the structures and then the cardiac chambers. I'll come to that, how we analyze. So this is how we say that where is the heart located, where are the various vessels, how are the chambers oriented to each other. And one more thing I would like to highlight here is that look at this part. As you can see, this is very densely opacified. So this is the area from where the contrast has been injected. Now I'll show you the brief points which should be seen. So this is the abdominal cut. This is the liver. This is the spleen. This is the gastric area. So that is how we decide the abdominal situs. And then we look at this. If we kind of scroll it here, we can see that this is the area of IVC. This goes and joins into this atrium, and that we can see over here. So it is IVC is connected to the right atrium. And this is the coronary sinus. And we can see that this is one ventricle. This is another ventricle. And I'll take you at this point. As you can see over here, this is right ventricle because this is the moderator band. I hope you can all see that. This moderator band is the band between the parietal wall and the septum. So all that can be seen on axial section. And then we go ahead further. Then this is at the level of RVOT, just below the aortic valve. And we can see that this is aorta in the center. This is the RVOT, left atrium with the pulmonary veins which are connected to it. This is the superior vena cava. And you can see that this is very densely opacified. And the reason is because we have injected contrast through this. We go further up, and as we can see over here, this is the branching, and this is the relationship of arteries, aorta and pulmonary artery. But when we talk about the great artery relationship, we should be seeing the aortic valve and the pulmonary valve. And I hope you all understand that. And this is the branching pattern of the like aortic arch vessels. And this is a solitary venous channel, which is on the right side. And that is getting the contrast. So I'm telling this because this is how we will interpret how venous channels will be seen. And for the orientation I'm giving, this is anterior, posterior, right and left, and I think that is obvious. So we'll go to the interactive session now. Shall we move ahead, sir?
Yes, please.
So this is for team 1, and that is Jai Deva, I suppose. So we'll follow the same sequence. I'll show you one axial section from below upwards. First, I will run all along. Then I'll stop at specific points to give you clues. And then I'll give you a little more clues. Okay. And we'll see how far you go in that analysis. So this 5-year-old girl with systolic murmur at left upper sternal border and STT changes in V5, V6. So I'll just run it for you. I'll allow one more running, and then I'll
do that a little
that.
slowly. The second run has to be slower than this.
Yes, sir.
Quite fast.
Yes, sir. So I am just kind of scrolling for you. I'm going from below upwards. Okay, and now I will give you the all bookmark places. So this is for the situs. This is for venous connection. This is for 4-chamber. This is for something which you have to notice and decide what is being shown. This is the abnormality which is in focus. And this is the arch vessel branching pattern. I'll go back to the area where you need to focus and tell me the diagnosis.
Jayadeva, you have to unmute yourself.
You want to see it once more?
Yes, sir. Yes, sir.
Okay. So now we'll start from below. Wait a minute. Okay, it's starting from below. I would like you to, kind of pay attention here. Okay. Since you're not recognize yourself, I'm giving you specific clues here. Pay attention to this 4-chamber.
You can think aloud. You can say what you find here.
Sir, in this view, there is both the atrium LA and this RA and LA are normal, but RV cavity looks hypoplastic, sir. I just want to see the rest of the run once again.
No, is it the chamber which is hypoplastic or something else?
Or something else.
The cavity,
the wall.
the hypertrophy of the RV, sir. Actually, RVH.
Okay.
Only RVH or
anything?
what about LV?
LVH, sir. Yes, sir.
Okay.
LV is more than RV.
And now, anything here? Any abnormality?
He just put his finger there. What do you see that?
That is a coronary, right? Coronary.
Normal.
Okay.
Right coronary artery appears normal, sir, but origin I'm not able to trace to the cusp, sir,
okay.
there. Okay.
Is it normal or is it
this?
something different?
I think it is dilated. I think you have
Dilated right coronary.
You have to understand this is a 5-year-old child, so it's dilated. Now this is the area which you have to focus and tell the diagnosis. I won't be telling anything more here.
You have practically told everything. There is not much left to say.
Yes, sir. I mean, so they are not so used to CT, sir. So I think we have to give them kind of.
I agree with you. Okay. So far, what you have said is hypertrophied both ventricles.
Both ventricles.
Left more than right. Dilated coronary arteries. And
what is shown in this?
The third part in this jigsaw puzzle is focus. So what lies above the left atrium in an axial view?
It's like parasternal short axis on echo.
Yes.
So what lies there above the left atrium?
In front of left atrium.
In front
Yeah.
At this place. What is this?
Aortic cusp and aortic valve levels.
So aorta.
Aortic valve.
Aorta. So is this
this is
aorta
aorta.
normal? So you
No, it
compare
is-
see the descending thoracic aorta and see the ascending aorta. Do you find any difference between the two? No, Saurav, you are changing the. Don't change the
Not
frame.
that, not
Let
that.
them
Yeah,
see.
this frame.
Okay. Okay, sir. No, I wanted to show them how it goes up.
So normally the ascending aorta is
aorta
bigger.
is large. Ascending aorta is larger, sir. Here, in this case, the descending abdominal aorta and the thoracic aorta look larger than the ascending aorta, which is seen here.
Is it that the descending aorta is larger or the ascending aorta is really small?
Ascending aorta is small.
So when you have a
So what do
smallish
you-
ascending aorta with a dilated coronary artery with a left ventricular hypertrophy, now there is not much left to say. What's the diagnosis?
Alcapa, sir.
Alcapa? Oh my God. Alcapa?
No, you are saying small ascending aorta, no? Smallish ascending
Smallish
aorta.
ascending aorta. And I may want to see the other great artery also in this setting. Does it help you? So there are two great arteries. One is the aorta and the second is the
pulmonary arteries.
Pulmonary is also looking,
very good. So if this were a disease which involved both hypertrophic,
I will take you to the diagnosis. Don't worry.
So hypertrophic left ventricle with a small ascending aorta, dilated coronary artery, and something wrong with the pulmonary arteries.
What are you looking at? We showed you a picture of that child also in my presentation.
That's the ultimate now.
Don't ask for which panel. Sir, we have to pass and ask the other teams.
I think we'll
should
go
be-
on. I think let's go on in the interest of time because we'll get late otherwise. So
Okay,
quickly,
so okay, I'll show you.
I think you should tell the diagnosis.
Okay,
You
you
just
see
reveal
this
it,
one
man.
now.
Helium syndrome, sir.
Yes,
Okay.
Williams syndrome,
And
or
you
you can
see
have
this
even
one.
without Williams syndrome, you can have supravalvular AS and peripheral PS. Okay.
So if you see
Non-Williams.
this VRT, I want you to focus on this VRT. And as you can see over here, the myocardium is so enlarged that the cavity is so small. And then you look at the dilated coronary. One moment, sir. Okay. And so this is dilated coronary artery, right coronary artery. This is the aortic valve or the cusp. And this is the narrowed supravalvular aortic stenosis part. So team Jayadeva, question is, what are the different causes? One is Williams, they have already said. Any other?
So the other one is
Familial hypercholesterolemia.
wrong
First,
answer.
you have to say non-Williams autosomal dominant supravalvular aortic stenosis.
Familial
Then you have to say,
hypercholesterolemia would not produce PS, peripheral PS.
that will not have peripheral PS, but if you have to say supravalvular aortic stenosis, you have to specify which type of hypercholesterolemia. It's homozygous type of hypercholesterolemia. Familial homozygous hypercholesterolemia. Okay, so we move ahead to the next team, sir.
Yes.
Scoring, I am not bothering, sir. I hope you are.
No,
already
don't
doing
worry.
that,
I'm
sir.
taking care of the
Yes, sir.
scoring.
Yes. So team 2 is thing from Sri Chitra. And here we go again with the CT axial from below upwards. And I'll run it again 2 times. And then we will pause at correct places. You have to tell the complete thing. In my own assessment, this is relatively easy. Okay. So I'll kind of pause at places where I want you to
guys are
focus.
lucky. They got an easy case in round 1
No,
as
but
well.
they have to tell the complete thing to get the marks.
Yes.
So this is the first section which you have to focus. Then this is the second one. This is the third one. This is the fourth one. And this is, okay, I should be here. Okay. So you have to tell the complete diagnosis.
So
and
it
the
is
word complete
situs
is important.
inversus, because the liver is on the left and spleen is on the right, and aorta is also on the right side. After that, we have dextrocardia. Then we have the right-sided ventricle giving rise to the the like veins are draining into the right-sided atrium, which is of LA like morphology, and it is this LA is draining to the right side that ventricle, which is of RV morphology.
Okay.
And after that, we can see that there are side by side great arteries with a right-sided aortic arch.
Why do you say right-sided aortic arch?
So the first branch, it is actually that mirror image branching pattern.
No, mirror image branching pattern is okay, but why do you say it's as right arch? What is right arch? What defines right arch as right arch? Branching is a way of identifying it.
Yes, sir. The abutment on the bronchus.
Yeah, so it has to be on the right bronchus.
Yes, sir. It is abutting on the right bronchus here, sir.
And one thing you have not told still, what is being shown here?
Here, sir, the three branches of the arch, and the left side that carotid is not was seen here. Probably it has an anomalous origin.
Say it again.
So the left carotid is not seen. So probably it has got an anomalous origin. Right-sided.
No, that is part of brachiocephalic. No, left is brachiocephalic.
Yes, and the thigh.
This is dividing. This is brachiocephalic, dividing into two. Question is, what is this? What is this?
This is, sir, the left SVC, which is draining into the left-sided right atrium.
Yes. So if you see carefully, actually there is no right SVC.
Yes,
if you see carefully, there is no right SVC. There is a connecting cava which drains as left SVC and goes down into that atrium. And this will become even clearer in these images, as you can see over here. So now this VRT shows something more. What is there? One more abnormality.
Coronaries are also there is a single coronary which is branching into the LAD.
So there is single coronary artery.
RC.
Yes. So I hope all of you can see that. This is a single coronary. This is the right coronary artery, and this is the LAD which goes into the septum. So this is AP view for the benefit of everybody. How do you, what is the peculiarity of IVS in the diagnosis which you have said?
Sir, it will be orthogonal.
But he has not set the diagnosis as yet.
Okay,
he has to
okay,
mention.
sir.
So he has just said right
Okay,
arch. Right arch is not the correct answer here. We are not we are the least bothered about this. Which side the arch is? Which side is the ascending aorta? Where is the aortic valve? What is its relation?
So you have to complete the diagnosis now.
Okay,
as you do for sequential segmental analysis.
Okay, there is situs inversus dextrocardia with no RSVC. LSVC is draining into the left-sided RA, and the pulmonary veins are draining into the right-sided atrium of LA morphology, which is connected into the right-sided ventricle, which is of RV like morphology, and side by side the so CC TGA, congenitally corrected TGA with situs inversus, the dextrocardia, and mirror image branching pattern
No, that's okay.
I think that's all right, sir. I think they have told almost everything. The focus I want to make here is that the in situs inversa situation in such a setting, it would be right-sided, right and anterior aorta, rather than left and anterior in the situs soletus situation. Sir, can we go ahead to the next question?
Last question, yeah, because we're getting late now.
Yes, sir.
Yes, proceed.
Okay, so this is for team 3. Okay, from MAMES. So I'll again run it. So 2-year-old girl, cyanosis, no murmur, normal S1 and S2. So I'll stop now and I'll show you. So this is the first, for the abdominal thing. You focus at this point. So we are going from below upwards. What are you seeing? Or okay, I'll show you all the sections. Now this is the next one. This is like 4-chamber. We are seeing this is in ventricle, this is atrium, this is another ventricle, this is another atrium. And I'll keep on scrolling it up. I'll go back. I come up again. And then this is at the level of pulmonary arteries. Bit difficult, but if you go in a sequence, you'll be able to pick it. And I'll assist you during the process.
I think you can offer some hints here and there because this is challenging.
Sir. Let them start, sir. I'll.
Okay, it's cytosolitis, sir.
Very good.
Okay. Yes, so this is the aorta. Okay, what is happening at this point?
So LV appears dilated, sir.
Okay, very good. So LV is dilated, as you can see in this frame, where LA and LV are dilated.
There is an inlet VSD.
That is, yes, there is a VSD. There is a good pick, but we are right now focusing on connections. So it's fine. I mean, you get marks for observing that.
And the AV valve appears common.
No, before that, just go down and come up. I think they missed one point.
So we are going from below upwards.
Just look at the venous structures and trace them up as they enter the heart.
I'm tracing it for you.
Yes.
So the venous structures, where did they go?
Like there is a common chamber behind LS.
Can you identify 4 chambers here? There is a septum here.
Yes, sir.
This is atrial septum. This is ventricular septum. So this is what?
This LS. Common
which is receiving pulmonary
veins are draining into, sir.
We are again going from below upwards.
Where are they draining? You said you started to say it.
SVC draining into LA.
Sir, look at the clinical scenario also.
Anomalous caval connection.
There is a common chamber behind LA.
Sir, anomalous caval connection to LA.
Which caval connection? Correct. You're on the right track.
Sir,
Started very well. You said some veins were draining and then you suddenly changed track. Why? Persist with that track. You are right.
You were right. So why are you getting confused?
SVC is draining into LA, sir.
We are right now below the
SVC.
IVC,
sir.
we have not reached to.
IVC is draining into LA.
Right. Very good.
Okay.
Very
what
good.
is,
and that
what
explains
what is the interpretation of these chambers? This right atrium is what? Normal size?
Makes it small, sir.
Okay. And now you look at this. So this is again the area where the contrast is coming from. Okay, keep tracing that.
Yes.
So now what is the diagnosis?
say AVSD with anomalous IVC to LA.
Why are you saying AVSD? Look at the AV valves; they are not like that of AVSD.
Okay, AV valves are normal. Okay, I'm telling you, AV valves are normal. Get out of the heart and see the connections. I think it's a bit difficult, sir. So
yeah, this is a challenging
shall
case.
I explain, sir?
Yeah, please.
Any
explain.
other team want to come in?
No, I think we don't have time, sir. It's already 8:35.
So if we go from below, if we see carefully, these are all hepatic veins. If we see also carefully, there is a venous channel over here, which is behind the diaphragm. So actually, this patient has IVC interruption. Hepatic veins are directly connected to the left-sided atrium, which is also receiving the pulmonary veins. And if we go further, even SVC is also connected to the same atrium. Then we go further. If you see carefully, there is another SVC on the left side, which goes down and connects to this left-sided atrium. Okay. So basically, it is all the venous channels, systemic venous channels, are connected to the left atrium. And if you see, if we want to see in the coronal section also, I'll show here the relevant thing. You can see. These are the hepatic veins. This is the SVC, and this is the left SVC. They are all connected to this large posterior atrium, which is the left atrium. And if you see the last part of it, where it ends, this is the site of, this is the IVC interruption, which is getting into the right SVC. Another important thing to see here is the bronchus. Both the bronchi are of the same type. So this is basically right isomerism with the venous anomaly. I'm sorry. This
we'll
was...
wind up. That's fine. Fantastic. We'll wind up. I'll just announce that Team 2 has scored the most, but the difference was very minimal between them and the others. But definitely, you guys did very well, Sri Chitra. Congratulations. But again, as I said, this is not so important. We don't have time for the audience round here, Saurav. We have to wind up. So I will, and I apologize for going beyond time. I will just ask Dr. Taragan to give some closing remarks, and then we'll wind up at this point of time. And of course,
Madam must be there. But anyway, I think it's been very interesting. Of course, I think the subsequent sessions were a bit esoteric or exotic cases. Obviously, I think it will be in the realm of pure pediatric cardiologists. I think general cardiologists will find it still very difficult and a little far-fetched to grasp CT anatomy and all of this. But I think it's been a very, very wonderful session. I think all the sessions have been wonderful. Of course, the experts were there to explain, even take us through the really complex problems. Congratulations to the experts, and obviously, I'm sure the fellows will. I'm sure they'll go home and read up pediatric cardiology, or I mean, I think that's probably the basic issue here. Most of us during our training probably don't get exposed to much of pediatric cardiology, and I think this should be a stimulus for them to go home and read congenital heart disease with interest. Thank you. Thank you, KK.
Madam. Thank you, sir. Madam, just a few words and I'll have Dr. Prabhakar.
Yeah, I think very interesting quiz. I learned myself being a pediatric cardiologist, so I think it was a bit tough for the adult cardiology, but I think all of them did very well. I would say that they made the right diagnosis, and this is the way to go. You are not going to see very esoteric things in your clinical practice or even in your exam. So I think you just were right. I would say you had the right amount of information and you did it well. So congratulations to all of you, whosoever the winner is. Thank you, KK. Thank you, Prabhakaran, for making it so interesting.
So while Sakshi is displaying the slide for the next event, Prabhakar, some closing remarks from you.
Right, KK, thank you very much. First of all, thanks to all the contributors, the faculty who contributed to this quiz. I think this was really wonderful, and as everybody says, we have learned a lot of new things. And I just want to place on record the amount of effort that has gone on into preparing this. And I'm very, very thankful to all the 4 faculty who provided the data. That's Ramakrishnan, Saurav, Dr. Arun Gopalakrishnan, and who is of course Navneeta and
Jay
Rangnath, right. So thanks to all of them. Thanks to all the participants who participated, and they really did well. I was thinking about my time as a resident, and I don't think I would have been anywhere close to these guys. They were really, really very good. And thanks to the PHFI team for putting up a great show once again, particularly the quiz and all the background work that goes on in creating this program. So have a great weekend, and we meet again. What's the next?
Yes, 21st January, and we have a 24-year-old with ascites and pedal edema. We're going back to the case because we believe it's rather more instructive to do these cases also. We can't just keep doing quizzes. So we'll try to have you think through a case and learn the lessons from it.
Right.
It's from Jayadeva, this case.
Thank you. So the next case will be a 24-year-old, as KK said, 24-year-old man with ascites and pedal edema. So very interesting case again. Of course, thanks to our teachers, Dr. Sanjeev Sharma, Dr. Tarakan, and Dr. Saxena.
Thank you all. Goodbye. And we meet again.
Yep. Bye.
Thank you, everyone. Good night.
Good night.
Thank you and good night.
Thank you, everyone.